My special thanks to Prof. Kleber and Prof. Brenda Scheller for having us here. I think if the topic is given to me, indications, I don't think you're going to get very much trials to show that, randomized trials to show that the indications for diffuse disease. I'm going to talk about diffuse disease as well as multivessel disease. So we had our own consensus, our Asia-Pacific consensus. I think Prof. Shin is also here. Dr. Rosalie is also here, where we look at maybe a different subset of patients in the Asian, where we have a lot of diffuse disease, small vessel disease. And I think Prof. Antonio Colombo and Prof. Latif, maybe you remember this paper that you had many years ago about doing DCBs compared to DES. I will not go through most of it, but basically there is a role for DCBs in certain vessels as well as a hybrid approach. And these balloons that were used were the Falcon as well as the Pantera. But I think I've not seen any more papers from both of you. I'm not sure why, but there are not many. So if you can see here, the maze and the other components is that they are quite similar in both groups. And also the endpoints, you find that basically there is a role for DCBs in diffuse disease as well. I will not go through that, but if you look at the endpoints as well, they are comparable in both groups. We can discuss that later, but you can see that there is a hybrid approach. Some of the DCBs, you need a hybrid approach, especially in diffuse vessels, and I think you took 25 millimeters as, more than 25 millimeters as diffuse disease. Right, the other one coming from the Korea, Prof. Shin is here. I will not go into much details, but also PCI in patients with multi-vessel and small vessels. And if you can see here that she looked at lesions that are more than 25. I think the average lesions is about 40 plus. And you can see that the DCB group as well as the DS group seems to do fairly well in the DCB group. And at least at 3 years, I think the composite endpoint and all that was similar and was probably better in the DCB group. I'd just like to highlight that we have a lot of patients with diabetes. And this is one of the things that even in Malaysia, that we have about 30 to 40% diabetic patients. And if you look at the MACE at 2 years, DCB seems to do better as well. And the other study is that you can see that there's significant better in the DCB group at 2 years compared to DES only. So the key findings in that, you find that basically the smaller vessels are treated with DCBs, the bigger ones with DES, and there's also a crossover with a hybrid lesion with DES as well as DCB. And in the multi-vessel CAD and DCB, you can see that there's lower MACE and significantly reduced stent burden compared to the DS group, only PCI. I think you know less stents are better. You do not want to have stent thrombosis, late lumen loss, and all that. So DCB definitely is an option in this very diffuse disease. There's another study, the long-term outcomes of drug-coated balloons patients with diffuse coronary lesions. I would just like to highlight here that the use of scoring as well as cutting balloons were used more here. And I think we have discussed this yesterday, that to get the drug eluted into the vessel wall, I think this is something that you want to do in most of your DCB lesions. So you can see that the efficacy of the drug-coated balloons as well as in diffuse disease, and there is a comparable outcome and probably a bit better outcome in this group of patients. So as you can see, TLR as well as the MACE seems to be favorable in the DCB diffuse group lesions as well. So I think these are the summary that I have, but I'll just show you some cases. This is a 57-year-old gentleman presented with inferior MI, a long lesion, diffuse disease in the left circumflex, and we use the sequence please in this patient. And if you look later, 2 years later, the vessel is still very widely open. And you can imagine the small vessel, if you put a stent, then you're a long stent, small vessel, the rate of ISR probably would be higher. Another patient, 58 years old, male, recent anterior MI, thrombolysis, risk factors of smoker, dyslipidemia. This is the sort of lesions that we get in most of our patients. And we used a DCB sequence please, a small one, a long one as well, for the distal RCA. And if you can see that the vessel wall is, the vessel is wide open. And we restudied later, and the results are still very good. Another patient, 66-year-old male, recent angina, risk factors, diabetic and hypertensive. The proximal part is very diseased, and there is ISR in the distal, mid to distal part of the RCA. So that was DCB'd as well, and the proximal part as well, we just DCB'd rather than put another long stent. That is the immediate results. 2 months later, the results is still good. A younger patient of 59, diabetic, hypertensive, and non-STEMI. You can see diffuse disease in almost the left system. And we dilated with the sequence please in the left circumflex and the LAD. And 6 months later, the vessels are still wide open. Okay, finally, a very young soldier, 32 years old, with a CTO of the LAD. And I think the speaker after me is going to talk about CTOs, but just to illustrate that, we open up the LAD and let the vessel grow. And you can see she's got very bad diffuse disease, but the LAD now is patent. I can't imagine putting long stents in this sort of patient. And subsequently, when we saw him later, he was asymptomatic. Okay. Right, so we look at our own data in our heart center. And in a nutshell, you can see that most of our patients that we treated were all with the sequence please balloon. And we look at very, very small vessels, 2.5 and vessels 2.25. And you can see the main patients are diabetic and hypertensive. And you can see that this is our vessels 2.5 and 2.25. Almost half of them were very, very small vessels, and we look at our data. And as you can see, most of the vessel size and the lengths are almost similar to each other. And you can also see that the outcome for both arms were quite reasonable. And if you look at these very, very small vessels, we find that it's comparable in both very small and 2.5 and less than 2.25. And the MACE at midterm was equitable in both of those lesions. So there was no real difference between the two groups. And as you know, we deal with a lot of small vessels, diabetic patients in our center. So we have a lot of experience with sequence please, with Prof. Kleber and Prof. Nuruddin. I think this experience that we had using sequence please in treatment of extremely small vessels was favorable and with a low MACE rate at midterm follow-up. And I think you can understand from the previous speakers, you do not want to put stents in these very small vessels. So when we first started using DCBs at our center, I think there were a lot of discussion with our colleagues that where is the data, why are you using this? you're accepting what you call results that are not stand-like. I think we went through quite a hard time, but as Prof. Sheller and Prof. Kleber has persevered, I think we are now at a stage where things are moving on, and we are probably going into this leaving nothing or less behind. And I think, as far as I can see, it's probably a hybrid approach, either DES with DCB in most vessels, or even a scaffold with DCB in the future. But as far as diffuse disease, I'm not sure whether we can have these strong randomized control trials in this. But from the real world, our experience in Malaysia, I think we have to adopt this policy because we can't be putting long, small stents in these sort of patients. So as you can see now, our usage of DCBs have gone up. And I must say the younger fellows that we train, in their mind is DCB first, why stent? So I think that has sort of changed our way of looking at, so it's DCB rather than stents, okay? So as you can see, the usage of DCBs over the years, when we first started out almost 10 years ago, was very minimal, and only a few of us were really into this. But now you see the acceptance rate has gone up, and things have looking much better, leaving less or nothing behind. Thank you.